All right. So again, thank you so much to those of you that are joining us today for our monthly session. Today we have a really good educational webinar on how a covered entity double their claims capture rates. So I'm going to walk you through the steps that this covered entity took to double their claims capture rates, and how you could do that today. 340B, we live in a world where it is being affected by manufacturer restrictions, and every prescription that you capture leads to further 340B savings. To those of you that don't know me, my name is Anthony Velasquez. I am the Chief of Product at PharmaForce. I've been in the 340B space for over a decade. Primarily, first half of my career, I worked for covered entities. So I worked at grantees, I worked at hospitals, I worked at big dishes throughout the country, where I had the chance to, and the honor of running several 340B programs. And the last 6 years, I have been on the technology side. So we have these webinars where I kind of share, this blend of what I learned on the covered entity side, what I know from the technology and TPA side. And my goal is to bring you value every month, every time that we do this, to bring knowledge to you as 340B professionals who are the ones that join these calls, and hopefully help you to manage your program better, and help you increase your capture rate, increase your savings, and help more patients. So that is my goal today, is to do that. Today I am solo. My partner in crime, Justin, is not going to be able to join us today as he is out with an illness. So we hope and pray that he gets better. Let's start with a quick disclosure. Nothing in this presentation should be constituted as legal advice. I just have to do that because of my position and the type of information that I share. So nothing in here is legal advice. Please confirm everything with your team, your compliance team, your legal team, as needed. This information is for everybody. Okay, so the fact that you're not a PharmaForce customer, even better. We want to help everybody regardless of where you are in your 340B journey or what vendor you work with. I don't care. I want to help you. I want to bring you value. So this is for everyone. Now, on the agenda today, as we walk through this journey of how this covered entity doubled their claims capture rates, it is something that we have seen multiple times. I'm going to walk you through what they did and what are the things and steps that you should make sure are 100% solid, checked off in your program, to make sure that you could do the same, or possibly just even make your program just a little bit better while implementing one of these changes. So we're going to talk about clean data and why the data that goes from your EMR to the TPA is so important, that data is accurate and complete. We're going to talk about implementing the right way. It is so important to get your implementation right from the beginning. I know that there's often the urge to rush your implementation through, make sure that you go live as soon as possible, but that can come at a cost of quality. So you want to make sure that you implement right. And I'm going to talk about some of the things to be on the lookout there. We're going to talk about data transparency, why you want to have a partner that has data transparency and that you could see sort of the back end of your own configurations and rules and things like that. We're going to talk about TPA logic. This is where the secret sauce is the TPA logic and the TPA's ability to maximize the capture rate for your covered entity. And then we're going to talk about manual claims review. So it doesn't matter if you have a AI-powered supercomputer claims processing engine that can find every single claim in the world. Ultimately, there's still some component of this that requires a manual claims review on a regular basis to find, trends and issues. So I want to talk about that, and I want to, talk through what that process should look like on a regular basis for covered entities. So let's get started. So clean data equals more claims. What does this mean? It is a very simple concept that If you feed clean data into a system, you're going to get clean data. If you feed dirty data, you're going to get dirty data. So you are always, as you're working with a TPA, it doesn't matter who it is. It doesn't matter who it is that you are implementing or working with in the 340B market. There are tons out there. But as you're working with a TPA, you want to make sure that you are choosing the data transmission process that best fits your covered entities. So if it is a flat file and you're going to send your TPA flat files, then great, so be it. If there's an opportunity to implement an HL7 data feed, which is a more sort of live interface where the encounter data is going to your TPA more on a regular basis, multiple times a day as it's happening in your EMR, versus the flat, which is one file with the previous day's activity, sometimes a previous week activity. That's also okay in certain situations, although you want to be careful that there aren't any major delays in sending that data. But this is key to the first step in ensuring that you're going to send clean data. What do I mean by that? The flat file sometimes comes with creating a data file, creating logic from an IT person that then has to send that data to your TPA, where the HL7 is sort of more standard, where it's sort of you turn it on, you do add some filters and some rules to it, but it pretty much sends everything that takes activity that happens in the EMR is then sent over to your TPA. You want to consider too, as you're doing this, right? So I'm walking you through this journey, right, of how to double your claims capture rates, and I'm sort of want to help you find the little gold nuggets that might be relevant to your 340B program. If you have eligible areas that have multiple EMRs, you might have a combination. You might need to send a flat file for one area and HL7 for another area. Maybe you can send flat files for multiple areas, but remember to make sure that you take into account if your system has multiple EMRs. I worked at a dish hospital that had 3 different EMRs, one for inpatient, one for the ER, and one for the outpatient side. So this can be very painful, and our data wasn't complete at a time where I was managing a 340B program, because we were changing the EMR and we just could not do another IT project to pull data from the one specific EMR. So that's why things like this are really important, because you could be missing significant amounts of data that are going to impact your claim capture results with your TPA. Okay, so once you've done that, once you've identified your data transmission, what makes sense for you, what your IT can sort of incorporate, whether you need to outsource or can do that in-house, then it's generating the types of files that your TPA requires. So things that are normal that you guys will all understand if you've been in the 340B space, your encounter data file. This is a file that usually includes encounter data from all of your eligible 340B areas. The one key thing here is you want to know your TPA's capabilities to handle locations mapping. So can your TPA turn off or make ineligible your non-eligible locations, or does your TPA only require you to send eligible locations in that file? There's entities that I talk to all the time that are sending their perhaps their dental locations, or are sending locations from departments that aren't necessarily generating prescriptions. Talk about your radiology departments, your other departments that are doing let's say small procedures that are not leading to prescriptions and things like that. Maybe you don't want to send that data to your TPA, or at a minimum understand what types of options you have to map the right locations. Same thing goes for your e-prescription data. If you have a health system that has eligible locations and non-eligible locations, you want to make sure that you are only including perhaps or mapping in the TPA the eligible locations to ensure that you increase your compliance, but at the same time also have a high capture rate. Then we have the provider file. So This is key. Many TPAs depend on the provider. Unlike the e-prescription data where some TPAs might not support it, the provider files are pretty common in the 340B space. Every TPA requires a provider file that I know of, and it is very important to maintain this list. Sometimes there are TPAs that can support interfacing with your credentialing department and getting the file and the data directly from them. There's pros and cons to that. I worked at a health system where there were like 3 or 4 resident programs, and all of those were managed by different people. So you had to get like your main providers from the credentialing department, and then you have to go to 3 different people to obtain the resident list for the different resident programs that the hospital had at the time. So this can sound simple, but it can be very complicated depending on your size and scope. And it is not very straightforward sometimes. So it is important that you're paying attention to this, that you are managing your provider files on a regular basis. A monthly basis should be a minimum time frame that you are reviewing your provider files to ensure that they are accurate, and providers that have moved on are no longer on that list, or have a termination date, and provider that have been employed have been added to that list and have an accurate start date in order to match up with your prescription capture. I know that sometimes it's difficult for CEs to get this data, so they have the tendencies of just adding whatever date, to the start date of the provider. It is really important, and I highly recommend doing the provider start date if you can, because that will lead you to the best, most accurate results. Location mapping, as I mentioned, is really, really important. A lot of the locations that are the locations that are 340B eligible have to be, if you're a grantee, they have to be, a location that's part of the scope of your grant. If you're a hospital, they have to be a location on your Medicare cost report that's reimbursable. So you want to make sure that the location mapping is a key process, or a key data point that you're tracking accurately, especially if you work in a big health system. This can be a big challenge. So building a crosswalk, if you work in a big health system, building a crosswalk that maps your Medicare cost report to your locations in your EMR, and how those translate into eligible and non-eligible, is a worthy exercise, and I highly, highly recommend that. But the location mapping is key to having clean data for your claims capture. Now, historical data. This is something that I do not want to overlook because it's really important. This could be the difference between a 10, 20, 30% capture rate in your data. But it is very important that your TPA load historical capture claims, historical encounter data or historical e-prescription data when you are, preparing for your implementation. Doing an analysis on that data to ensure that it aligns with what reports that you have, in terms of if your, let's say your primary care clinic does 12,000 visits a year, and you're sending a historical yearly file and it only has 5,000 visits on it, then that should alert you that there's a problem and maybe there's data missing. So it's really important that this step happens, that you confirm the historical data was loaded, and that your TPA is able to do a data volume analysis for you to make sure that data is loaded in the third-party administration platform. All right, so that's that. So we're starting with clean data. The data has to be good. It has to be clean. It has to be properly formatted. It has to be properly filtered. It has to be identified to be from eligible locations. So what's next? Next is implementing the right way. Again, I mention this all the time. I know that as a covered entity, I was there. There's times where I look back and I was like, oh man, I was such a jerk with my TPA because I want to go live super fast. But I know that there's the tendency to want to just go live yesterday. And I want to assure you that the quality is so much more important than the speed, though they can go hand in hand. But the quality is really key, because if you start your implementation wrong, it is a nightmare to undo it, okay? once you're live, if you didn't send the right data, if you went live without the proper, without understanding the proper configurations, and your capture rate is low, and then you're trying to, dig into with your TPA to see what's going on, it is a very difficult exercise, very time consuming, very difficult to pinpoint exactly what happened after you go live in some cases. So I highly recommend that you implement correctly. It is critical for the long-term success of your relationship with the TPA. If this starts bad, it's very hard to, to fix this and turn this around. So it starts with understanding the TPA qualification logic. Ask a lot of questions. Please, during the implementation process with your TPA, if you're in that process now, ask them a million questions. Make sure that you understand, show up, pay attention, be alert. Ask them what is the best practices, what are other entities doing, what are other entities your type doing to maximize capture rates. Asking the right questions could be the difference in you having a successful implementation or not. But understanding the qualification logic of, hey, how do you handle patient eligibility? How does your full-time provider logic work? Do you support e-prescription? You say that you have provider plus encounter. Does that have a look back period? Can I set up certain groups of provider to not look for an encounter, but others to look for an encounter, right? You want to understand all these intricacies of how the TPA can function. And then ultimately you want to understand the unique configurations and what the TPA can handle. So how does the TPA handle a look back period? And they go back a year if you wanted to for certain providers, but for others, you only want to go back, 30 days or 7 days, or things like that. Their date checks, how do their date checks work? So if you're doing a look back period, are you matching against the date on the written date on the prescription or the date of service on the prescription? Believe me, that might sound trivial and that might sound like obvious, but it is not. Some TPAs have different logics in how they do their date checks, and I will share more on that because that's very key and something that sort of we've discovered and sort of learned doing this for as long as I have. But the Medicaid check, how does your Medicaid check logic work? Does it work on the primary payer and the secondary payer? What if I'm in a state where if Medicaid is a secondary, we don't want to block Medicaid for the secondary because the state doesn't request a rebate? Do you have logic that supports skipping a Medicaid check when Medicaid's a secondary, right? These are all questions you want to ask, and you want to know, because all these small things add up and compound to leading you to having a really high capture rate, okay? Your provider check. Again, how does that happen? When I update my provider, how far back does it look? Does your system do automatic reprocessing when I add a new provider, et cetera, right? All these questions you want to ask. Your manufacturer blocks, how does that work? Can I see it, et cetera? And ultimately, you want to audit the claim results. I know that some entities, want to review every prescription that is eligible on sort of that first reprocessing. So every TPA, at least I can speak from the process that I'm familiar with, but once you do an initial claims processing, you're able to then show results and say, hey, this is what we were able to find in terms of claim capture rates. Please review this. Pay attention to that, because that could give you a lot of really good insight into how that TPA logics work, and allow you to audit that against your EMR and make sure that you're having a high compliance rate, but at the same time, not leaving anything on the table. All right, so we talked about number one, we talked about having clean data. Number two, we're talking about getting implemented correctly, understanding the configurations, right? I'm walking you through these steps that are critical to having a high capture rate that led to this entity of ours doubling their capture rate, right? Number three, I think, is really important, and that is you could do it right. You could have the cleanest data, right? You could sign off on the best configuration. You could say, man, I feel like I got this. I understand it. I know how this TPA works. I know how their configurations work. But ultimately, you need the data transparency. I'm very big on this. I I hate the black box approach. I hate the approach that you can't see what's going on, how your program is configured at any given time when you so choose. Um, I think that is wrong and that should not happen. But it happens way too often in our space. So one of the things that I encourage you is make sure that even if your TPA doesn't have the ability to show the configurations in their user interface, ask them for a report. Okay. If you have a TPA who says, hey, sorry, we don't let you see your manufacturer blocks, for example, in the user interface, say, hey, can you run me a report? It's really important that I lay eyes on this. I want to see how this is configured. Maybe you want to see your look back periods, your provider panels, your Medicaid blocks. You should be laying eyes on that stuff periodically. If you are managing your 340B program, if you have a consultant that's doing this for you, that's probably what they're going to do. They're going to want to do that. So I highly, highly recommend that you work with a TPA that gives you this access, or ask your TPA to pull this data. They are able to pull this data from a backend table and send it to you in an Excel spreadsheet or something like that. But it is really important for you to have access to your configuration and your data. Ultimately, you want to do things like track your monthly volume, right? So again, you want to know that when you're implementing, going live with a new TPA, or you have just a grasp in your program of, I know I capture on average 500 claims a month, right? Or 1,000 claims a month. Well, you want to track that. So if you capture 1,000 a month, you have 2,000 that are non-captured a month for your patients. You want to see that those numbers are sort of stable or average on a monthly basis. And if they're not, and one goes up or another goes down, then that might lead you to look further into something that might be wrong with your program. Okay. Something that might have changed in the data. So having transparency of the configurations and your claims data will allow you to keep track of monthly volume, volume by pharmacy, volume by location, volume by provider, these sort of types of key data points that will help you find gaps in your program. Okay. If anything goes wrong, by looking at this data, you should be able to point out, wait, we just went down by 25% month over month. There's a problem here. Let me dig deep. Let me figure out what's going on. Is it that my wholesaler failed to upload? Is it that my TPA has a delay? And things like that. So I'm very passionate about this because I think it's so key. And 340B should not be a black box. There should be transparency. So please demand transparency from your vendors, your TPA partners, to make sure that you can see what's going on with your program. All right, next is the TPA logic and capability. Pay attention here, because this is the one, this is the juicy stuff. This is where I'm going to give you the good information. So this is really key. Not all TPAs are made equal. TPAs, some were built a long time ago. Okay. Some TPAs have been around since the early 2000s. Some TPAs are newer. Some TPAs, are more experienced. Some are bigger, some are smaller. They're different philosophy, different product manager. So you might be tempted to think everyone's the same. Everyone has the same logic. Everyone has the same approach. Everyone is basically the same. And that is so far from the truth. Actually, we're very different. We're very different in our approach to solutions. We're very different in the way our technical capabilities are implemented. So I can tell you for sure that I have seen on multiple occasions covered entities double their capture rates by switching TPAs. And you might be asking how, like, is it really that different to go from one TPA from another? Because I have the same question, right? Coming from the covered entity side, coming from the TPA side, I assume, well, hey, everyone is the same. I mean, it's pretty normal stuff. You just check the prescription against the encounter and the catalog and the Medicaid. And so we're all the same, right? And then I quickly found out in my early days that was not the case. And I'm still learning a ton of how different we all are. So here's a few things that I think will surprise you of how TPAs are very, very different one from another. Number one is e-prescription support. Believe it or not every TPA can support e-prescription data. So I believe e-prescription, we at PharmaForce believe e-prescription is the gold standard in prescription capture. So being able to match the prescription that was adjudicated at the pharmacy to the prescription that was e-prescribed through your EMR, and having a one-to-one match on those two, we think is the gold standard in claims capture eligibility. Okay. So if you're not doing e-prescription support, I think a lot of the market has moved towards that. There's still some TPAs that don't do it, but this is a biggie. This is one that might be leaving significant amount of opportunities, especially around refilled or renewed prescriptions where the patient didn't go back for a visit, but the prescription was renewed. This is an opportunity where e-prescription helps close that gap. Number two, RX written date check. This was a shocker for me, okay? Where I was under the impression every TPA did their prescription checks where they're matching the encounter based on the prescription written date, and that is not the case. Some do it based on date of service. Some TPAs in the market, might be a TPA you're using, does it based on date of service, so that if the encounter falls out of the 365-day look back, for example, because the data service is extending, because refill 00 had a data service of October 1st, refill 01 was November 1st, refill 02 was December 1st, refill 03 was January 1st. As those are sort of increasing the data service, you're going to have that maybe you only capture 5 of the 10 refills, or 4 of the 8 refills, because the way the TPA logic is written. The correct way is to do it based on the RX written date. So that one was one that shocked me, and it is surprising to me that that happens, but it happens. Next is name mismatch check. So as you all know, working in healthcare, that the names that is entered for a patient in the pharmacy software system does not match the name that's entered for the patient in the electronic medical record often. Okay. It is very common every day, millions of records, all of the time, this is happening. So a lot of TPAs have either one, they don't have an ability to match that, so they have an exact match logic, which then leads to them just failing the claim. Okay. Number two, some say, hey, here's a mismatch, but they will not, they will just flag it as a close match. And then some TPAs are able to use technology to match it based on close match proximity. So you want to look at that as well. This is a big one. I've seen upwards of 15% increase on that one. Claims reprocessing. Once a claim is tested once, is only tested once, and then that's it. It's not retested again. So some TPAs have that capability, and the multiple wholesaler support. It's another one that you want to look for. All right, time is running out, so I'm going to breeze through this last slide. But even after all of that, okay, so we went through all of that, all of those things that you should have in your program, or the TPA logic that you should be aware of in order to help you double your capture rate. Even after that, it is critical that you have a manual claims review, that you're reviewing your ineligible claims, that you're maximizing your capture rate. I recommend you review these weekly, maybe even monthly, in order to find gaps in your program. There is a ton of data in the non-capture claims. If you're not looking at your non-capture claims, I highly recommend that you start today, because you're going to learn a ton of information by looking at that data. You're going to find issues with your configuration. You're going to find opportunities to make updates to your program, etc. So it is really important that you sort of merge great technology and claims capture TPA logic with this manual review function, and you're going to have the best of both worlds and fully maximize your 340B capture rate to the best of your capability. So I hope you found this information helpful. I would love to take some questions. If you all have any questions, please put it in the Q&A. please raise your hand, and I would love to unmute you, and we could chat about 340B stuff or any questions that anyone has. But I hope you found this information useful. Thank you so much for your time. We try to keep this to 30 minutes because we know everyone's really busy and wants to go back to their full-time job. So I appreciate your time so much, and thank you for joining. This will be on our YouTube channel. We're going to send a recording of this out so that you could share with your team, or go to our YouTube channel and view this webinar. But again, please post any questions that you have. I'll stay another 5 minutes or so if I see that anyone's interested in asking questions to discuss. And thank you for joining today.